to our first presentation. Please allow me to introduce our speakers. First of all, we have, so I'll be just reading bios for Steve, Julie, and Dr. Charbonneau. So Steve Crochetiere, in 2010, Steve became a paraplegic following a motorcycle accident. Like so many people living with a spinal cord injury, Steve struggled with UTIs, which caused social isolation, lack of confidence, and depression. After being introduced to hydrophilic catheters, Steve made it his goal to work for Coloplast, the company that changed his quality of life with their catheters. Throughout his journey, Steve worked for SCI Alberta as a peer coordinator, co-founded and directed the advocacy group Wheels of Change, started his own medical supply company, was a key contact for residential FES cycling, and was the appointed Northern Alberta peer lead for the Alberta Skills webinars. In 2021, the opportunity Steve had been striving for came along. And after vigorous interview process, Steve was the successful candidate for the position of territory manager for continence care in Alberta with Coloplast. Today, Steve continues to impact the community with his passion for quality product use and equitable coverage for all. Steve has received accolades through his work for his unique perspective as a person with lived experience and through the community for his honest advocacy. Steve loves experiencing new adventures with his family and cheering for his beloved Cincinnati Bengals and Montreal Canadiens. Julie Reeder is a registered nurse, clinical nurse educator, and a Canadian Nursing Association certified neurosciences nurse. She has spent her career working with persons with neurological disorders, such as stroke, brain injury, and spinal cord injury. And over the past 13 years, Julie has practiced as the clinical nurse educator of the spine unit at the Foothills Medical Center in Calgary, specializing in spine surgery and spinal cord injury, and supporting nursing practice, education, change management, and knowledge translation. Julie has participated in creating and sharing many of the patient and healthcare provider resources available in NHS for management of neurogenic bladder, and continues to sit on the provincial working group to standardize care for patients with spinal cord injury in hospital. Dr. Rebecca Charbonneau is a clinical associate professor in the Division of Physical Medicine and Rehab in the Department of Clinical Neurosciences at the University of Calgary. She is also the medical lead for spinal cord injury rehab at the Foothills Medical Center in Calgary. And Dr. Charbonneau graduated from McMaster University in health science before completing her med school at the University of Western Ontario. She moved to Nova Scotia to complete her residency in physical medicine and rehab at the Dalhousie University. She has a research and special clinical interest in the prevention and management of complications following spinal cord injury, as well as the delivery of healthcare services following spinal cord injury. Welcome.
Thank you, everyone. And our talk today is on bladder health after spinal cord injury. And thank you, Casey, for introducing us, so we don't have to do that. Steve is a territory manager for Coloplast, as you heard in the intro, and we don't have any other disclosures. And this is the overview for our bladder health talk. But let's cut right to the chase because we don't have a lot to cover and not a lot of time.
All right. Thank you, Rebecca. So I'm going to point out the importance of this slide. I think it's very impactful on the rest of our conversation. If you see here, you can see bladder function being the second most concerning issue for paraplegics and the fourth most concerning for quadriplegics. And if you would have told me this before my accident, there's no way I would have believed you. Walking would have always been your first concern. That was always the thing that people noticed the most. But after living with a spinal cord injury since 2010 and realizing that my bladder management was that much more important day to day than the ability of not walking or not being able to walk, that making bladder management one of my top priorities in my life moving forward.
There's over 86,000 people living in Canada with a spinal cord injury, and most of them have neurogenic bladder. Historically, the mortality rate due to renal insufficiency in persons with SCI was quite high, above 50% back in the 1960s. And this has dropped substantially to less than 3%. And this is with the advent of catheter use as well as medications to manage changes that occur to the bladder. When we talk about bladder, it's really important to understand the sympathetic and the parasympathetic nervous system. So these are both part of the autonomic nervous system, or think automatic. So things that happen without you having to think about. This nervous system is interrupted after spinal cord injury. The autonomic nervous system regulates all involuntary processes, including things like breathing, heart rate, blood pressure, bowel, bladder, sexual function. And on this diagram, you can see the bladder illustrated at the bottom and then innervation from both those systems. So on the left side, you have the sympathetic nervous system. This is located in the middle of the spine or the thoracolumbar region, responsible for fight or flight. So when you're in an emergency, you need out of it, the sympathetic nervous system is activated. And when this happens, no peeing occurs. On the other side, the right side, the parasympathetic nervous system, this is at the top and the bottom, so cranial and sacral regions. And this area is responsible for rest, digestion, and peeing. And it's important to talk about the anatomy as well when we talk about bladder function. So here's the kidneys, and then the tubes going to the bladder, the ureters. You got the bladder, the sphincter or the valve at the bottom, and the urethra. To pee, that bladder muscle has to contract and the sphincter has to relax. So it's a coordinated function. And then to store urine, the opposite occurs. And these functions are interrupted after a spinal cord injury because the nerves destined for the bladder are no longer working or not working properly in some cases. These are the two patterns of bladder dysfunction that we see clinically. So for simplicity, just think of it like an injury either above the level of T12 or below the level of T12. Really, we use urodynamic studies to help sort out what type of bladder function patients have more accurately, but initially this is sort of the best way to categorize things. Luckily, like the approach to treatment for both of these types is pretty similar with respect to catheterization. Patients with the flaccid bladder, so injuries below T12, can have a much more difficult time staying dry though, especially with things like coughing, laughing, transfers, any Valsalva, and may catheterize more frequently and might need to use incontinence garments.
So when we are meeting people with spinal cord injury and we need to know about their bladders, we can take a history and do an assessment. The history is really going to depend on whether your patient or your person you're interacting with has a new or a remote SCI. A person with a new SCI is not going to have a lot of bladder history to tell you about. They probably have never thought about how they pee before. And so this is a new concept to most people with new spinal cord injury. You may have somebody with a history of BPH or bladder cancer or something like that, but generally, this is a pretty foreign concept. People with remote SCI, however, will have a lot to say about their bladder routine. And so you want to know about their current bladder management and their routine, their ins and outs, how much they're taking in, how much they're putting out, signs and symptoms of complications, and then the functional stuff like hand function. How does it get done? Who does it? The assessment pieces are pretty simple. It's all about that functional stuff, right? What is their motor exam with regard to hand function, and their AIS score gives us some of that prognostication. It gives us some classification so we can know what to expect with regards to hand function. When taking a history from a person with a remote SCI, it's important to discuss and ask about any of the techniques that may have been used in the past but are no longer recommended, such as using a condom catheter to catch overflow incontinence, using a Creed maneuver, or straining to void. Any of those will increase bladder volumes, and we'll talk about why that's bad.
So as far as investigations, renal ultrasound is sort of the most commonly ordered thing. people with spinal cord injury are increased risk for bladder stones. And if these are caught early, they're quite a bit easier to treat. There's also an increased risk of kidney stones. So often, if a person has a kidney stone that's obstructing, they might present with atypical symptoms like nausea or decreased appetite with the spinal cord injury. So the ultrasound is really important in identifying these as well. Urine culture is typically ordered if a UTI is suspected. Cystoscopy, which is a camera inside the bladder, is called for when there's a history of blood in the urine, if there's recurrent UTIs without a known cause. It's used for Botox injection into the bladder, which we'll talk about a bit, as well as removing bladder stones if they're there. And then finally, urodynamic studies, or UDS. This is really the gold standard test. So this is looking at the bladder pressures and the muscle activity. If there's high pressure in the bladder, this is what's associated with that renal deterioration or long-term risk of renal failure. So really important to know about. Also important to mention that, renal function decline can occur at any time. So even up to 45 years after an injury, making lifelong upper tract surveillance utmost importance.
So the goals of bladder management are to achieve regular bladder emptying. And in acute care, we start with every 4 to 6 hours. We want to empty that bladder because we want to avoid stasis, have 6 hours of that urine being in the bladder, max amount of time. We want to avoid those high volumes that Rebecca was talking about. So we keep our volumes below 500 mils, no more than 500 mils in a bladder at any given time, to keep the fill pressures low and to avoid high voiding pressures. To preventing the complications of stasis or failure to empty is really what we're doing here. We have some acute complications, and really those are autonomic dysreflexia. We'll talk about why that's important in a minute. And then there's the chronic ones that Rebecca was talking about, UTI, reflux, stone strictures. We also really want to prevent unplanned voids and overflow and incontinence so that we can promote maximum independence.
Thanks, Joe. Yeah, based on my experience, one of the biggest things that stood out or has stood out is UTIs. And I've experienced everything from just minor symptoms to be treated at home with water, antibiotics, or worst case scenarios, hospital stays on IV. So preventing UTIs becomes a main focus, and not just because of those hospital stays and whatnot, but also because the quality of life. Having UTI means frequently emptying your bladder, leading to more catheter usage, right? And then the effects on normal everyday things like maintaining a job, traveling, going out with friends, family, and so on.
So almost all types of neurogenic bladder will need some level of adaptive bladder evacuation. And by that, I mean catheters. There are some people that can manage with just conservative management or behavior only, which is like timed voids, double voids, limiting fluid intake and caffeine. But generally, everyone will need some kind of catheterization. So we have intermittent catheters, which are the clinical preference gold standard, because generally they come with fewer complications and they're better for long-term bladder and renal health. And then we have our indwelling catheters, and those are further divided into urethral catheters and suprapubic catheters. Now, it used to be we just took everybody's Foley's out and made them do in and out caths right away because that's the best clinical choice, right? But we're all growing and changing and becoming better humans. And one of the most important things to consider in the decision about what type of bladder management might be best for an individual is not just what's best for their human body, but also what's best for their lifestyle, for their desire, convenience, their educational or occupational needs, like Steve was talking about. It's not just about whether they have the hand function or the cognition to perform this task. Does this work for their life? And so that discussion can be difficult to navigate. So we have created a guide for healthcare providers to help with that conversation with patients, especially patients who are new to spinal cord injury. And you can find this resource if you use this QR code in the bottom of the screen here, and these slides will be shared. So we choose intermittent caths when we have an output of about 2 liters per day. Any more than that, and intermittent caths with our limits become very inconvenient. You have to do them so often that it's not worth it. You kind of have to have the hand function or the ability to use an adaptive device in order to perform ICs. We're going to call them ICs from now on, or a person to perform them. When in the hospital and we are starting with that, okay, we're going to start with ICs now. This is the resource that we have created provincially, and it should be used across the board provincially for times and volumes. This is based on using a bladder scanner to identify what those volumes are, but you'll see there's also sort of, you can come to the end and start transitioning away from using a bladder scanner, because obviously people don't go home with a bladder scanner, right? There's also conditions for mixed voiding as well. So this resource is also available through this QR code in the bottom corner here. And we really recommend that this is how every inpatient's neurogenic bladder is managed across the province. We also have some other provincial resources on how to do ICs. So you have the clinical care topic here, again, QR code if you are not familiar with that. And then there are some resources for nurses, including videos on Lippincott procedures. So that's available provincially as well. When transitioning from a provider-performed intermittent catheter to a self-cath, there's a little bit of a gray area. When should it be sterile? When should it be clean? What kind of devices are we going to use? So there is a guide for that as well. Again, you're right. QR code. Please use the QR codes and find our resources.
All right, so here, 3 different types of in and out catheters. First, we have the uncoated catheter, which of course you have to apply lubrication to. And then before inserting, and then it could be messy, and the lubrication doesn't always stay attached to the catheter as you insert. And then also, as an end user, you have to carry around lubrication and wipes to clean up that mess after. And the wipes and lubrication are an out-of-pocket expense. And secondly, we have the second one is a pre-lubricated catheter that you don't have to apply lubrication to. The lubrication is already on the catheter. Okay, so there's no need to carry around lube, but wipes you might need to clean up after. These can be messy and isn't necessarily the best option, in my opinion. And then lastly, there'd be a hydrophilic catheter. This is a catheter that the coating's already bonded to the catheter. So no need for lube, wipes, no mess to clean up after. And then the coating also doesn't come off when you insert it or withdraw it. So it's less traumatic to the urethra. And then also AADL, Alberta Aids to Daily Living, they did take note of the impact on the quality of life, the decreased UTIs, and the ease of use these hydrophilic catheters have, and they created a category. So anybody using a catheter now can get approved for these single-use catheters. And then the next slide that would be on would be just catheter sizing options. So the slide would show all the different French sizes. So French size is the diameter of the catheter, and they can range anywhere from an 8 French to a 20 French, but the most common would be a 14 French. And then you're going to have different lengths. So shorter ones for shorter urethras, larger for the larger urethras. And then there's going to be different types. So a straight being the most common. But if patients have issues inserting a straight catheter, they can move or get recommended a coude catheter. A coude catheter has a tip that is slightly curved upwards on an angle. And that's both to get around the L bend in a larger or male prostate or male urethra. And then also it helps get past an enlarged prostate. And then lastly, we have a flexible tip catheter. So it's got an oval head, and it's a little bit flexible tip, and it works both as a coude or a straight. The next slide is the slide with catheters that have a sleeve. Sorry. So these are hydrophilic catheters as well, but as you can see, they come with a protective sleeve. So this protective sleeve is sometimes known as like a no-touch catheter. So you actually never touch the catheter when inserting. You move it over top of the sleeve. So there's less chance of bacteria entering the urethra and less chance of UTIs. And this, in my opinion, is the best option if you're using an in and out catheter. All right. And then lifestyle catheters is what we would call those. Lifestyle catheters are very compact and discreet catheters that are easy to carry around. So you can see there's one in the bottom left corner if that slide comes up, but it's a male catheter or a larger catheter that can be extended, but it's small enough that it can fit into like your jacket pocket. And then there's a couple other options. So there's catheters with bags that are attached to them. So it's an all-in-one system. They have a catheter with a bag attached. That's easy. It's compact. It's discreet. It's easy to carry around. It's great for traveling. It's great for just out in the community or as needed.
So when we want to go to an indwelling catheter, so we talked about the ICs. Some people may choose this because it does give them more independence, especially if they don't have that hand function that allows them to be more independent with their ICs, because you don't need great hand function for it. And also intake isn't a factor. So you can have a higher intake and a higher output. This goes for both types of indwelling. People may choose the suprapubic choice, which is a surgical minor procedure to make a stoma through the abdominal wall into the bladder. Some people find that this provides improved sexual function and experience and improves their body image. It also clinically, it bypasses any urethral damage or obstruction, stricture, erosion, prostatitis, like all of the structural issues that we may have in the passage to the bladder. Some disadvantages of an indwelling catheter, a urethral one, it can cause meatal erosion, scrotal fistulas, epididymitis. So there are some, again, structural concerns. And with the suprapubic catheter, there's a risk of leakage because there's no sphincter on that stoma that's created. So some people do have difficulties with that leakage. Overall, using an indwelling catheter as compared to an IC, it does put you at higher risk for bladder stones, hematuria, bacteremia, which all lead to increased risk of cystoscopy, which is not a non-invasive procedure. And then also, if you have a catheter for more than 10 years and also you smoke, it increases your risk of bladder cancer.
All team members in rehab and in the community are involved in a successful bladder management strategy. And this is, of course, informed by the patient goals. So to help reach the bladder management goals, therapists and nurses will work on so much with patients, but some of the things that they work on include things like improving hand strength, range of motion, tone management, obviously working on bed mobility, transfer techniques, wheelchair skills, clothing management, even clothing modification recommendations like certain zippers or Velcro can be helpful. And ultimately, it comes down to a lot of troubleshooting with the patient, and then practice is key in order to help learn catheterization techniques. There's lots of adaptive devices available too. So here, there's illustration of a mirror that's attached to a leg abductor with a light. There's also a clamp that can be used if there's reduced hand function. There's a pants holder, and there's a catheter guide, which is called the Astacath. Medications are commonly needed, not always, but it is common. Most of these medications help to improve the bladder capacity as well as the pressures. And then this in turn helps reduce incontinence. Medications like solifenacin and maribegron are commonly prescribed together if one isn't doing enough. And medications like Flomax can help patients who can void at least some to empty more completely. In studies where people have indwelling catheters, medications like ditropan were associated with less risk of hydronephrosis or kidney swelling and should be considered. And Botox has really been a game changer here. So it has less side effects like dry mouth, and it's very effective. It lasts anywhere from 6 to 9 months in most patients, and it really helps reduce autonomic dysreflexia and has been found to result in substantial improvements in the UDS parameters as well. There's lots of surgical options. Typically, these are used when, the non-invasive methods are failing. So if there's severe incontinence, changes to anatomy, renal failure, or multiple UTIs, patients will look into the surgical options. And then we want to talk a little bit about the complications. So as I said at the very beginning, renal failure was the previous leading cause of death, but catheters and medications really changed this. And most complications are more likely to occur due to a failure to empty the bladder effectively or suboptimal medication management. So this is like things like UTIs, hydronephrosis, and stones. Next.
So ultimately, oh, sorry. Rebecca, can you see?
Yeah.
Okay.
Next slide. Just go to UTI.
Okay.
Yeah. So when we talk about UTIs, like this is a really common complication that I see both inpatient and outpatient. So it can be tricky. Patients and care providers need education to avoid doing random urine samples without signs and symptoms of infection because the culture can be positive even though there's no UTI if there's colonization. Typical symptoms of UTI like burning or urgency might not be present after a spinal cord injury. So the complications or the symptoms might be things like foul smelling urine, cloudy urine, hematuria, fever, increased spasticity, bladder pain, and autonomic dysreflexia. And then when we talk about prevention, hydrophilic catheters offer a significantly lower incidence of UTI and a lower risk of bleeding, strictures, and less urethral trauma. So yeah, Steve, maybe you could tell us about switching to hydrophilic catheters, how that impacted you.
Yeah, absolutely. So, I mean, hydrophilic catheters was very impactful in my life. Just going from washing and reusing to constant UTIs and, like in the description, just lower quality of life, depression, not wanting to go out, right? And then switching and finding a hydrophilic and it coming into my life and just the less UTIs, more confidence, the little things like less things to carry around with myself, when I'm in the community. And all of this leads to the better quality of life, going back to work, hanging out with friends, families. And I think just all in all, just making one of the biggest changes in my experience as a spinal cord user with a spinal cord injury and a catheter user. Sorry.
Yeah, if there's a catheter that's indwelling, it's been there for more than 2 weeks, please make sure this is removed before drawing a urine sample off of it. And the duration of antibiotics recommended is between 7 and 14 days, so a little bit longer than sort of a classic UTI. This is the UTI diagnosis algorithm. It's available only for AHS employees, but there's a QR code if you do work for AHS, and it's compatible with the antimicrobial stewardship. As far as other things to prevent UTIs, in the absence of data, it's always hard to know if these are helpful. Some things like cranberry or diamanose are not harmful. So I think, these can definitely be used without too much worry. But there is some evidence that in some cases, being on daily antibiotics for prophylaxis can be harmful due to increasing the risk of antibiotic resistance or things like C. diff infections. I alluded to this earlier, but there is an increased risk of stone formation after spinal cord injury, and hydration is very key. So if you're doing ICs, that 2 liters a day is a good target. And if you have an indwelling patient with indwelling catheter, the 3 liters per day is the target.
And Rebecca has touched on this many times, but really the renal failure is the big problem here. And it starts with hydronephrosis, which is a result of high bladder pressures. It's all just backing up in the system. So this is why we need a good bladder routine in order to make sure the bladder is empty to avoid this. Another reason is to prevent autonomic dysreflexia, which we talked about before as one of the acute reasons you want to empty the bladder. You've probably heard about it before, but just in brief, AD is unmitigated fight or flight. And as Rebecca discussed, those systems are broken after spinal cord injury if it's above T6. So the parasympathetic can't slow down the sympathetic, and you get a really high blood pressure, or high for that individual. And as we know, an increased blood pressure can lead to risk of stroke or death. So super dangerous, life-threatening. Definitely something we want to deal with right away. And once again, we do have a QR code for you that leads you to the Care for Patients with Spinal Cord Injury in Hospital page that has the provincial autonomic dysreflexia protocol and the patient card, the AD card, and it has a QR code on that card to the protocol, so they can take it to their providers, to EMS, to Emerge, and say, this is something that needs to be treated, and I need you to help me. Okay, thank you for listening to our presentation, and sorry for the interruptions. The slides will be available, and does anybody have any questions?
Thank you so much for the fabulous presentation. And now for those of you who didn't know, including myself, Zoom bombing is what happened. So thank you guys so much, and for powering through that. I appreciate it. I have a question. Is there a way to retrain the bladder to pee again?
Yeah, that's a really common question that we get. I guess the answer is sort of it depends. So, if a person has a complete spinal cord injury, it's very unlikely that there's going to be any ability to kind of regain that function, just the way that the nerves go to the bladder. Some patients who have an incomplete injury, so that means some partial function is still there, they might find things like pelvic floor physiotherapy to help augment bladder function. But at the end of the day, yeah, every patient is so different.
Okay, I've got another one. Is there increased risk of stones after an SCI related to decreased fluid intake?
Yeah, it can be. So, in some patients, they're perhaps not drinking enough, whether it's because, they're on a routine for doing intermittent catheterization, or their preference is just not to drink that much fluid. But the increased risk of stones also has to do with the spinal cord injury itself. They're not really sure why, but there's still this increased risk after a spinal cord injury, and it goes up quite a bit if there's an indwelling catheter there. So if there is a source for bladder incrustations to form on, then these can be a nidus for stones to form.
Thank you. Is there a way to prolong the window of catheterization / voiding overnight to allow for increased sleep duration and quality?
Do you want me to take that? Yeah, medications can help. Things like Botox into the bladder or Vesicare Mirabegron can certainly help with that. The issue is that we still want to avoid that urinary stasis when you're doing in and out catheterizations, because you're already at increased risk for UTIs having to introduce a foreign catheter into the body. So really, it's hard to stretch that window too long, but some patients are able to get to that sort of 7 or even potentially 8 hours without UTIs. If they start getting UTIs, obviously go back down to that 4 to 6 hours.
Yeah, and just like from my experience as a user, like I think fluid intake before bed is a massive thing too, to try and prolong the gap in between to get a good night's sleep.
Okay, we've got another one. Why are in and out catheters preferred over indwelling? Would indwelling catheters have lower instances of UTI due to less time you're inserting it and the chance of bacteria entering?
I think I can answer this one. The indwelling catheter is it carries with it a fair amount of risk because it's a permanent vector for bacteria. Whereas intermittent catheters, even though you're reintroducing a new catheter every time, there's nothing for those bugs to crawl up on. And this is why, you know, for the rest of our patient population, we also recommend getting those indwelling catheters out as soon as possible for our surgical populations and any like medical patients who are in the hospital. So there is a lot of good evidence that indwelling catheters are not ideal if you can avoid them. And you also then don't have that increased risk of stones, of erosions. There's just a few more complications. And yeah, it just overall, it's a better clinical choice.
Sorry, my mute was sticky. Are the medications covered through Alberta Blue Cross? And does NIHB cover hydrophilic catheters?
To the second one, yes. NIHB has excellent coverage for hydrophilics.
They actually just raised their benchmark to a $7 per catheter, up to 6 a day.
Wonderful. And the first question, I haven't had too many patients have difficulty with Alberta Blue Cross getting things like Vesicare and Mayor Bigron covered. If patients need a newer version of Vesicare because of side effects, and those ones usually need special authorization, but often can get covered. Yeah.
Okay, I think that's all the questions that I have right now. Thank you guys so much for that presentation, and again for muscling through. I did report that guy that popped up, so
Thanks,
hopefully
Dawn. That was crazy.
that was really weird. I didn't know that was a thing either. So thank you for muscling through.
I'm glad
sorry, there's one more.
Time.
I don't know if somebody can take it. We've got just enough time. Does AHS provide pelvic PT for SCI patients as outpatients?
Oh, I don't know of any pelvic physio that's covered. I could be mistaken, but yeah, I'm not aware of any. Steve, do you know?
I don't. I'm sorry.
Well, Dawn has her hand up. A different Dawn.
Hi, sorry, this is Dawn. I'm the practice lead for physio at U of A Hospital, and there are some pelvic floor clinics in the city of Edmonton that are AHS funded, have AHS funded appointments for patients, and that can be found on the AHS website for community physio services.
Thank you.